Hello. Hope you can hear me.
Yes, sir.
Yeah, my name is I'm Shane Halpe, Senior Registrar Family Medicine from the Sri Lanka College of Specialist Family Physicians. So, good evening to you all. So today we have gathered together to for another CPD program, evidence-based approach to childhood wheezing. So today's resource person is Dr. Hasitha Gajaweera. He's the pediatric pulmonologist at National Hospital Galle. And without any further ado, so let me invite Dr. Hasitha Gajaweera and a few housekeeping rules as well. Make sure you rename yourself with the Zoom name similar to that should appear in the participation certificate. And towards the end of the lecture, a link will be shared in the chat box. Please fill out the provided form. And note that attending the lecture for a minimum of 45 minutes and completing this form are necessary to obtain the certificate. The certificate will be sent to you via email within 1 week. And please keep your microphones muted and videos off throughout the session. If you have any questions, kindly type them in the chat box. They will be addressed later. So let me invite Dr. Hasitha Gajaweera. So over to you to deliver your talk on evidence-based approach to childhood wheezing. Thank you.
Okay, thank you, Shane, for that kind introduction. Good evening, all. I will be discussing in next half an hour also about evidence-based approach to childhood wheezing. Okay. Okay, why today is important? Is it due to this local government election or something else? Yeah, it is important due to World Asthma Day. Today is our World Asthma Day. And the motto for this today Asthma Day is make inhaled treatment accessible for all. Okay, objective for this presentation is preschool wheezing and school age wheezing. What are those? And what are the possible treatment options to preschool wheezing? What is MART and ART or AIR? And what are the risk factors for wheezing? What to consider when starting an inhaler? Can childhood wheezing be a risk factor for late life COPD? I will be not discussing fine details about any guidelines like GINA or well-established guideline because it is well available online. I'll be tell some important point for you to important as a primary care physicians. Okay, don't hesitate to put your any questions in your chat box or you can ask at the end of the presentation. Okay, childhood wheezing. There are two main entities. We do have preschool wheezing and we do have school age wheezing. Preschool wheezing, we are categorized from age 1 to age 6. And school age, it is more than 6, going up to 12 plus, going up to adolescent age as well. Wheezing is not always asthma. You may be here, so many parents coming to you and telling, my kid is having asthma, and lot of social ha-ho about wheezing. Is it really asthma? Before jumping into the diagnosis, we need to take good history, detailed examination. There may be category of patient who's having isolated chronic dry cough, maybe due to asthma. Now, sometimes back, a few years back, there was this name called cough variant asthma. It was taken out from asthma classification for a few years. Now again, this diagnosis or the category is back. Okay, therefore, there's a thing called cough variant asthma. Investigation. Are there any specific investigations? Yes. For the asthma, school age asthma, yes. But for the preschoolers, mostly none. And we need to tailor the investigation when we are diagnosing preschool wheezing. What is called asthma? Is it airway inflammation or Is it variable airflow obstruction? Or is it bronchial hyperresponsiveness? A doctor said so. Oh, once I got an inhaler in the past. Oh, what? Now, asthma is all of this. Anyone can name as asthma for any of these things. Nowadays, asthma is not a particular diagnosis. Is it a sort of a nomenclature or a syndrome? We are, is it similar to anemia or arthritis? You know, if you tell arthritis, there are a lot of categories of arthritis like rheumatoid arthritis, osteoarthritis. If we tell anemia, hemolytic anemia, aplastic anemia, so on and so forth. For asthma as well, we can give the name of asthma, but it is not given any idea what is the underlying biological pathway or endotype is going on. Therefore, asthma is sort of a syndromic name. Keep that in mind. Okay, moving to the preschool wheezing, which is wheezing in early part of their life before 6 years of age. It is not about bronchiolitis because we are excluding bronchiolitis. When that is recurrence or when that is problematic only, we are thinking about preschool wheezing. Is it really wheeze or is it upper airway sound or rattle, stridor? These are burning questions when you are practicing day to day. When you are auscultating also, you will hear some noise, okay? And you need to ask clearly from parent as well as when you are auscultating also, you need to differentiate whether these sounds are really wheeze. And this is very important. Normal preschool child can have 10 calls per year with symptoms lasting 2 to 3 weeks. That means any kid can have any cold sort of symptom once in 2 months maximally. It may be more than that, 1.5 month like. And there's a thing called nursery school syndrome. This may be facing you as parents when you are having a nursery or daycare going kids. This is usually happen for the first kid. And when we are placing, because of our service commitment or any other necessity, we may be putting our child to preschool early or daycare early. They may be gathering repeated viral infection one after the other. The recovery may be merged into the next infection. Therefore, parents will come and tell, okay, my child is always having some kind of cough and cold or any upper airway sort of symptoms all throughout the year. And they are not responding to antibiotic or even not for the inhaled corticosteroid. Therefore, that there's a category called nursery school syndrome, and they may be fall into preschool wheezing category as well. I will tell how to differentiate that. If you are getting a preschool child with cough and wheezing, they may be normal child who's getting recurrent viral cold, a pertussis, or nursery school syndrome, as I told. Or they may be having a serious underlying illness like bronchiectasis, cystic fibrosis, or childhood interstitial lung disease. Or may having asthma syndrome, as I told earlier. They may be having episodic viral wheeze or multiple trigger wheezing. Or that may be a minor mimic or exacerbators of symptoms like allergic rhinitis, infective rhinitis, or gastroesophageal reflux disease. Or maybe over anxious parents concerning about their child's symptoms overly. This is happened mostly to the first-time parents. Anxiety following a non-child death. You know, recently there were social media how about 2 children death in 2 main hospital. And then the people may come and seek medical advice from their nearby doctor or consultant. The main worry behind this medical visit is that child death in their near vicinity. Okay, what are these early viral wheeze or the episodic viral wheeze and multiple trigger wheeze? Episodic viral wheezes are wheezing only with clinically diagnosed respiratory tract infection. In between, there are no symptoms at all. They are only getting symptoms, particularly during that infective episode. They may be catching viral infection, they may be showing the symptom, and it is going away. The multiple trigger wheezes are wheeze with viral respiratory tract infection, but also they have infection symptoms in between the symptoms or in between the infections as well. They may be showing some symptom with excitement or the exhaustion or allergen exposure. But these are not having these two categories not having any connection to the endotype. You know, endotype we are categorizing asthma into some categories according to the biological pathway. Say, for example, maybe one endotype is Th2 inflammatory pathway in all endotype. Others may be neutrophilic inflammatory pathway, something like that. But these episodic viral wheezes and multiple trigger wheezes are not connected with the endotypes. While we are talking about these wheezes, preschool wheezes, we should aware about what are the red flags, what are the alarming features. If they are having prominent upper airway symptoms like stridor, maybe having a nasal obstruction, that kind of thing. Or if they are having symptoms from their day one of life. If someone present to you at 2 years of age and mommy or daddy telling this kid is suffering from these kind of symptoms from the day they discharge from the PBU or from the postnatal ward, that is alarming. And if they are sudden onset, I think you can think of sudden onset cough. What is the thing we need to think? Foreign body inhalation. And if someone is having wet cough for more than 8 weeks, again, we need to alarm. And if they are having a reflux symptom, which is suggestive by a worse after feed or irritable feeder, if they are having a arch back following feeding or vomiting, need to think about the gastroesophageal reflux disease. Or if they are associated with systemic illness, or if they are having recurrent otitis media or persistent meningitis, UTI, are these the people, or are these people patients suffering from immune deficiency? Or if they are having continuous or unremitting symptoms. These are the red flags history findings to be alarmed of, and then we need to investigate. And this is the natural history of usual viral induced wheezing and viral infection. You can see within 1 week or maybe by 10 day 10 of illness, it may be settled. And there may be an infection which will go for up to 4 weeks, but not beyond that. That's why we are categorizing this chronic cough of symptoms, wet cough persisting more than 8 weeks. And this category of patients will have symptoms building up and going beyond 4 weeks and continuous more than 4 weeks. These are the category of people whom we need to be alarmed. What are the investigations or the examinations we are worried about? If they are having clubbing, if they are having significant weight faltering or reduction or weight loss even, if they are having upper airway disease or nasal polyps, turbinate hypertrophy, signs of allergic rhinitis, or if they are having chest deformity, or if they are having fixed monophonic, chest deformities are like pectus excavatum, carinatum, or scoliosis even. And if they are having fixed monophonic wheezing or stride or asymmetrical sign, those are the things we are thinking. Whenever we come across a patient who's having monophonic wheezing, we will be thinking of foreign body inhalation or airway mass inside the airway or slow growing mass. Or if they are having signs of cardiac and systemic illness, those are the examination findings which we should alarm of, or which we think take seriously. Okay, now we know the features, what to look and what to examine. Before we go into or suggest the management for these kids, we need to categorize. We need to cluster these symptoms and signs into 3 categories. That's called deconstructing the airway. There may be a category whom having fixed and variable airflow obstruction. They may be having bronchoconstriction, airway anatomical instability, intraluminal mucus. Now, no point of discussing these things without knowing whether these people can be treated or not. That's why we need to identify or categorize these three categories. And this is the category, this is the treatable trait 1. If they are showing bronchodilated response, we should prescribe beta-2 agonist. This is for preschool visas. And next category, if they are showing airway inflammation features, if they are there, what is the cell type involving it? Maybe eosinophil inflammation or neutrophilic inflammation. And is it getting the treatment, is it going to be beneficial or not? What is the pathway involved for this airway inflammation? Those are the things we need to be thinking of while we are treating. That is the treatable trait 2. Is there airway eosinophilia? If so, we can start inhale corticosteroid. How can we check airway eosinophilia? Do we really need to do bronchoalveolar lavage always? Not really. Now evidence show airway cell cytology or airway cell composition will be presented or represented in the systemic circulation. Therefore, if we having a troublesome child who's having a recurrent symptom, we can easily do a full blood count and look for eosinophilic count. And whether they are having an ongoing airway infection and impaired host defense. They are the people who will be benefit from antibiotic. We can treat with short course of antibiotic and check. And again, their airway will be rich of neutrophil. And keep in mind, there are 3 categories of treatable traits. One is having bronchodilator responsiveness. One is having airway eosinophilia, which is responsive to inhaled corticosteroid. And the third category is responsive to antibiotic. Therefore, there's no hard and fast rule, sort of a template treatment or the cocktail treatment for each and every patient. We need to categorize them and treat them separately or choose the particular category of patient who will be responsive to each category of treatment. Okay, what are the management options we have? We do have beta-2 agonist and anticholinergic. For preschool users, are they going to be helpful? There was a very big studies about the responsiveness about the beta agonist. They are having a variable and unpredictable response. And no clinical features to identify which infant or preschooler will have symptom response. Therefore, we may need to give trial of therapy. Most of the time, they are responsive in our experience. But if they are not responsive, no point of continuing bronchodilators for months or weeks. Can we use nebulizers? Yes. Nebulizers for metered dose inhalers. If there's no hypoxia, we can use metered dose inhaler via a spacer. If we are suspecting hypoxia, make sure we are introducing bronchodilator therapy with oxygen. For the acute episode, we can give oxygen therapy and IV max sulfate, which is out of scope of this participants. Okay. One important area again, role of steroid in preschool wheezing. There's a big systematic review done by Castro Rodriguez, which was published in Pediatric Pulmonology in 2016. Are they going to be helpful? No effect on hospital admission. No effect of unscheduled healthcare visit. There's one other study which was published in Lancet Respiratory Care in 2018. It will reduce the length of the stay. Overall, most children, no benefit for the preschool wheezing. Oral corticosteroid is mainly hospital-only medicine, but we can use when we are having a significant wheezing who's not responsive to conventional bronchodilator therapy. Maybe non-genomic effect. It will reduce an airway edema. Therefore, we need to use the oral steroid judicially. Role of steroid in preschool wheezing. What is the role when you are using inhaled corticosteroid? There are two categories. We can use it as an intermittent therapy or continuous therapy. Will that prevent disease progression? There's a COPSAX and PEAK and IFWIN study. No benefit for the disease progression. And it won't reduce the episodic viral wheezing. Is that all? No. For the multiple trigger wheezes, it will, in severe attacks, and if we are thinking parents are underreporting the interval symptom, we can easily start a trial of therapy, inhaled corticosteroid. We can start 200 micrograms budesonide or equivalent medicine per day for 6 weeks via spacer and see the response. If child is symptomatically improved, we can continue therapy, and after some time we can stop. If they are getting the symptoms back, we can start a minimum required dose, not as higher dose as 200. And if they are not responsive to inhaled corticosteroid, we need to consider alternative diagnosis. If there's no symptom, no need of treatment. Okay, moving to the antibiotic or the treatable tree. Role of antibiotic in preschool wheezing. Azithromycin, you know. Azithromycin is the answer for most of the question, but we don't know the question. It has multiple effects, antibacterial and anti-inflammatory and antiviral as well. And no benefit in macrolide unless acute or severe symptoms or if there's past history of SDU admission or PICU stay. You know, nowadays we are facing a big trouble because of macrolide resistant mycoplasma. We are getting a lot of complicated pneumonias following mycoplasma infection, which is not responsive to conventional macrolides. That is the main at the disadvantage of overusage of azithromycin. You can see here, azithromycin against a placebo, there's no advantage over a hospital stay. Okay, one important drug, which is very famous among our practitioners, Montelukast or leukotriene receptor antagonist. There are comparison between intermittent versus continuous regimes. There's no benefit for the preschool wheezing, but some individuals might have some benefits. Therefore, we need to be again very, very cautious and very selective when we are using. Keep in mind, no drugs is without any side effects. Even Montelukast will give neuropsychiatric side effects up to 10 to 20% of that's users. That means night terrors or poor night sleep, that kind of thing. Therefore, make sure you are educating them about this kind of symptom in small percentage of people. And if someone is getting this kind of symptoms, we need to stop the treatment. We need to look for any other options. Okay, now we are moving to the childhood wheezing, school age asthma. It's a bit different from the preschool wheezing. And there will be very, very prominent or the very obvious history of variable respiratory symptom. And it is the commonest cause for school absentees. You may be knowing as a parent who is having school-age children, that is the most commonest thing to have school absentees. How can we confirm? There are a lot of things. Spirometries are widely available. Then we can do FEV1. It will be reduced. And excessive variability in the lung function test. And the bronchodilator reversibility, if that is more than 12%, it is 12% different. It is suggestive of asthma. And peak expiratory flow over 2 weeks. If you can monitor peak expiratory flow over 2 weeks, if that is there's Diana variation more than 13%, that is suggestive. And if there's significant increase in lung function after 4 weeks of anti-inflammatory therapy, again, that is suggestive. If we can induce the symptom with exercise challenge, and which is shown by reduction or drop of FEV1 more than 12% or peak accelerator for more than 15%, that is again suggestive. Positive bronchial challenge test, even it is hardly doing in Sri Lankan setup, or that is available option, methacholine or mannitol or hyperventilation, hypertonic saline, and excessive variation in lung function between visit. Again, those are the things which will be helpful for us to diagnose the symptom. But as respiratory physicians, we are not freely, or we are not doing this test for each and every category of patient. We will be doing it for difficult cases or who's having not uncontrolled symptom despite proper treatment plans or any atypical symptoms. Okay, now we made the diagnosis. How are we going to treat? What are the goals of management? Achieve good control of symptoms and maintain normal activity levels. While we are thinking to achieve this kind of thing, we must always discuss with parental expectation or goals. Unfortunately, in Sri Lankan context, what we are seeing most of the time, mainly in the adults, rather than they are targeting the proper symptom control or having a proper quality life, they will be limiting their activity levels to contain within that their capability. That means if they are having restricted exercise capacity, they will be limit their activities to that level, and they will be happy within that level, which is not the therapeutic goal in asthma treatment. Therefore, when it comes to childhood asthma also, we need to discuss with parental expectation. And while we are treating, we need to minimize the risk of asthma flare-ups, impaired lung development, drug side effects, and drug side effects with the minimum possible drug dosage. What are the management options for asthma? Beta agonists are there, anticholinergics are there, inhaled corticosteroids are there, leukotriene receptor agonists are there, and biologics are there. Out of these, biologics are out of our scope because this is not important for primary care physician. That is for mainly the tertiary care centers, biologics. Unfortunately, currently we don't have much availability of biologics for the government sector, but hopefully it will be available in the future. If anyone having any question about biologics, we can discuss after our lecture. Okay, again, an important slide. No short-acting beta agonist allowed. This was implemented since 2019 in GINA guideline. Why it is prohibited or not recommended? It is increase in the asthma death, which was revealed in asthma death review in UK, which was done a few years around 2016, which shows most of the asthma deaths are due to overuse of salbutamol. Why is that? It will, if even 1 to 2 weeks of regular salbutamol usage will downregulate the beta receptors, and it will decrease the beta bronchoprotection. And there will be rebound hyperresponsiveness, and it will decrease bronchodilator response. And it will induce pro-inflammatory pathways and increase eosinophil counts. And it will again increase allergic response as well. And on the other hand, it will lead to vicious cycles of encouraging overuse. Salbutamol will give a perception because of this nature of having bronchodilate response. Whoever having symptoms due to bronchoconstriction will feel relief of their symptoms. Therefore, patient will think, okay, this is the only drug which is giving a supportive or the advantages to us, not the preventers. Therefore, they will move toward the salbutamol. No point of using the preventers. We will go for the relievers. Therefore, they will overuse salbutamol than using the preventer medication. That will lead to overusage of salbutamol, and that they are the category whom having the death, unfortunately. That's why No SABA alone for the asthmatic. It is mostly for the more than 12 years, but which we can practice after 6 years. Therefore, don't prescribe. If you are sure this particular patient is having asthma, don't prescribe as salbutamol or the short-acting bronchodilator alone. Okay, now we are moving to two important slides and two important concepts, which is called anti-inflammatory reliever therapy. We are using this anti-inflammatory therapy for the step 1 and 2, whom doesn't needed, whom not warrant to start regular therapy, whom only needed bronchodilator response when they are having a symptom onset and they are not having very frequent symptoms. We are using budesonide formoterol. Unusual dose is 200 over 6 micrograms. We can use one inhalation whenever needed for symptom relief. Can use 100 over 6 for the small children more than 6 years. And it is recommended only after 6 years of age. And maximum recommended dose per day is 12 actuation or 12 inhalation within 24 hours. Make sure, keep that in mind when you are educating patient. That is 12 doses per day. If that is less than 12, that is 8 doses per day. If someone is using more than 8 inhalation, they should seek medical advice. Maximum 6 inhalation at one time. And because of lack of availability in our setup, even we can use salbutamol beclomethasone combination. There's no combined inhalers including having salbutamol beclomethasone. Therefore, we can use these two inhalers together as for anti-inflammatory reliever therapy, because there is only medication available which we can use for the AIR in government sector. Maintenance and reliever therapy, which is called MART. It is single inhaler maintenance and reliever therapy. That is step 3 to 5 in adults and step 3 to 4 in children. When someone or when a patient needed a regular therapy or maintenance therapy, this is the way forward. Evidence for budesonide formoterol as well as for the beclomethasone formoterol combination. But in Sri Lanka, only budesonide formoterol combinations available. As government sector only having beclomethasone, we can use together with beclomethasone, salbutamol inhalers combined for this MART therapy, which is controversial bit, but as it is not available, the budesonide formoterol, we can try on that as well. Dosing, budesonide formoterol for MART, for adults and adolescents, 200 over 6 microgram, one inhalation twice daily as the maintenance therapy, and we can use extra 10, that total 12 per day, 24 4 hours. If they are using more than 8, they should seek medical advice. For the children, more than 6 years, actually we can use after 4, but mostly what we are using after 6 years. Maximum doses are 8, 1 morning, 1 nocturne, and 6 in between. And maximum of 4 inhalation at once. If they are having symptom not controlled with one puff, we can use another puff, not go for another puff, 3, and if still not controlled, we can go up to maximum of 4 puffs at once. Okay, now we are moving forward, and if we are come across a patient who's having asthma symptom despite of inhalers, before we are stepping up, before we are going up in the scale, or before we are going to the next step. If symptom control poor despite 3 months of adequate therapy, make sure you are minimally giving 3 months of anti-inflammatory therapy. Don't change the inhalers one month apart or in monthly basis. Don't worry. You continue inhalers for 3 months. If that is not responsive only, we are changing. Even at that time, make sure symptoms are due to asthma. Make sure you are taking a good history and you are making sure these symptoms are due to asthma. And you should check and correct inhaler technique and make sure the patient is having good adherence with prescribed dose. And consider trial of other treatment for that step. With as add-on therapy, Montelukast, or we can change the inhaler types. And if there's risk factors like allergen sensitization or smoke exposure, we can control them. Okay, what are the risk factors for poor control asthma or poor symptom control? Medication. If someone is using SABA more than 3 canisters per year, they are the category who's having risk of exacerbation. If someone is using 1 canister per month, if they are using more than 12 canisters per year, that should alarm you. It will increase the mortality. Even the patient claiming I'm having a fairly good control, if they are using SABA more than 12 canisters for 12 months, you should alarm. That is not well controlled. And if they are having other underlying condition, maybe having obesity, chronic rhinosinusitis, gastroesophageal reflux, or food allergy, we should be cautious of. If they are having exposed to smoking, the air pollution, we should be consider that as well. And one important aspect in these days and our newer society, the psychological stress. Is it only for adults? Not. And even a kid may be having poorly controlled symptoms while they are facing for the scholarship. Due to the unnecessary stress level they are going through during that 5-6 months or maybe a year. Therefore, make sure you are asking about that and make sure you are discussing these matters with the parents. And if they are having lung function less than 60%, FEV1 less than 60%, or if they are having bronchodilator responsiveness more than, now for the diagnosis, more than 12% we are considering for asthma diagnosis. If they are having a bronchodilator reversibility more than 20%, that is considerable difference, considerable responsiveness. Therefore, we need to be alarmed. These are the category who may be having poor asthma symptom control. If they are having evidence for type 2 inflammatory markers like very high E count or elevated FeNO, you know that exhale nitric oxide level, which we can do in most of the teaching hospital as well as in some general hospital. Or if they had a past history of ICU care, or if they had more than one exacerbation in last 12 months. Those are the category who may be having poor asthma control in the future. Okay, now we identify this category. How can we choose an inhaler device? For the pediatric patient, mostly the pressurized metered dose inhaler. And it must be used with valve spacer device, with or without mask. Mask, is it really necessary? Yes. Up to the age whom they can use a spacer effectively through the oral, the mouthpiece without the mask. Because we need to take away the mask whenever possible. Because the effectiveness of the drug delivery will be more through direct spacer than we are using with the mask. And we need to check inhalation technique, and mainly the tidal breathing is important for the proper inhalation, and optimum number of breaths. Now, it is not a mantra. Now, we need to go with the logical aspect. Now, if, say, for example, if someone using a space of 350 ml and they are having a tidal volume of 100 ml, only 3-4 breaths will be enough to empty that spacer and take the drug in. Therefore, no point of asking them to having 10 to 12 breaths for each actuation. Therefore, be rational and be logical when you are asking someone to take inhaler. And what is the best volume? It is better if you can use less than 350 ml. And most of the commercially available in spacer devices are having less than 350 ml. And if we want to give 2 or 3 of one drug, what is the better way or best way of delivering that? Is it single actuation or multiple actuation? The evidence tells single actuation will be having a more drug delivery and more efficacious delivery than the multiple actuation. Therefore, advise them to have single actuations. And time between the actuation and inhalation, we should done it the time we need to keep the spacer connected to the or keep inside the mouth, and then only we need to activate. Otherwise, the efficacy or the delivery will be low. And we need to make sure the valve is moving while they are inhaling, inhaling the drug. And make sure we are advising parents to check the valve efficacy even before the usage of the drug or activating the inhaler. And the cleaning of the spacer. And we need to make sure we are keeping that electrical static nature or the electrically zero charge nature of the inner surface of that spacer. We can wash with detergent containing water without rinsing. Better not to touch in inner surface to keep that electrically static. Okay, what is the best way? Okay, now these are some mistake which we come across while we are checking the inhaler technique. Now you can see this valve is outside the spacer device. And this kid is using metered dose inhaler without a spacer. And this fairly a bigger girl using an inhaler with mask, I think she's more capable of using without a mask. And interestingly, this kid is using this spacer to drink something. And how to choose the inhaler? Now we are moving away from the metered dose inhaler. Now we are talking about dry powder inhaler. When patient can produce satisfactory inspiratory flow, if someone produce more than 30 liters per minute, sort of, actually the desired flow is 60 liters, satisfactory flow, we can switch from metered dose inhaler to dry powder inhaler. I've seen in some clinic visits, the small kids are using dry powder inhaler, which they can't produce a proper or adequate inspiratory flow. Therefore, make sure when you are prescribing dry powder inhaler, whether the kid can produce adequate flow. There are several categories: DP inhalers, breath activated devices. But interestingly, these dry powder inhalers are environment friendly. I will tell it about next slide. That is called Go Green. You know, for the metered dose inhaler, there's the supportive gas to the better delivery of the drug, which is called hydrofluoroalkane, which is again a greenhouse gas. You know, sometimes like which we have changed this activated gas or the containing gas inside from chlorofluorocarbon to hydrofluoroalkane, but still it is a greenhouse gas. Therefore, whenever they are capable of using a dry powder inhaler effectively, we better switch from metered dose inhaler to dry powder inhaler. But while we are thinking about the inhaler environment, we need to make sure the patient is having a better symptom control. Therefore, don't be rushed to change the inhaler, but make sure you are thinking about the environment while you are managing the kid as well. When we are comparing with dry powder inhaler with the metered dose inhaler, you can see here the carbon footprint, the carbon production will be very high with your using of metered dose inhaler. Okay, make sure you are producing or providing a self-management plan to the parent with the basic explanation about the asthma and factors influencing it, correct inhalation techniques, and with when to use reliever therapy and how long you need to use preventer therapy, sort of with this signal light or the traffic light coding. Okay, are there a way to prevent this asthma? There are a lot of studies going on. Nutrition of the mother and the baby, it is very important aspect for the asthma prevention. Maternal diet, allergic food exposure. There's some evidence about if mother had the allergic food exposure, the offspring will have less incidence of asthma, but not confirmed, and there's no enough evidence to conclude that. Definitely maternal obesity and weight gain during the pregnancy will cause increased incidence of asthma by 2 to 3%. Dietary supplement of vitamin D. You know, vitamin D was a very exciting drug for most of the disease. But for the asthma, not having direct evidence, but for the maternal supplementation will reduce some incidence of asthma. Again, the evidence is not much. Probiotic, there's two again no much evidence, but some evidence are there to prevent. The maternal probiotic will reduce the incidence of asthma. Inhaled allergen, pollutants, maternal smoking, traffic-related air pollution, which will increase the asthma incidence. Microbial effect, you know, farm, the people, small kids who brought up in farm environment or the you know, that poultry and with the living with poultry industry, they are having less incidence of asthma, and as well as they whom delivered through vaginal delivery having less incidence of asthma. Some medication like by big wide spectrum uh, um, you know, this high potency antibiotic or the paracetamol usage will increase the asthma incidence, but again, not having very good evidence. Therefore, better to avoid this kind of thing. And psychological factor, you know, people nowadays are living with more stresses than in the past. Therefore, they are having more incidence for asthma. And obesity and the female gender also increase the incidence for asthma. Okay, last slide. COPD and childhood asthma. Whether there's relationship? Yes. What are the risk factors to develop COPD in later life following childhood asthma? If the mother is had asthma or paternal asthma is there, childhood asthma is there, or mother smoke. And because in our part of the world, most of the mothers are not smoking, but we are exposing to passive smoke. We don't have much evidence for passive smoke and the asthma, but there should be a good relationship. And childhood respiratory infection also increase in the incidence. Now, who are the category whom having a later life COPD, high risk of developing COPD, whom start having lower lung function who started, and whom not having catch up of the lung function or not having lung function gain. And if someone's lung function is deteriorating or reducing very quickly, they are the one whom having a later life COPD risk with childhood asthma. Okay, I'm going to stop by telling this take-home summary. Preschool wheezing can fit into several categories, and we need to be vigilant when we are managing it, and we need to take a good history and examination. Preschool wheeze is an umbrella term for complex and different clinical clusters. Should assess deeply before commencing some specific treatment option. AIR and MART, which is very important. I think you can keep this concept. You may be aware, but keep this concept in your mind when you are after this lecture. Is the way forward for school age asthma management. Wheezing in early childhood carry risk for late life COPD. Okay, thank you so much for your kind attention. Thank you.
Thank you very much, sir, for your insights on preschool child wheezing. And let me invite the audience to put forward your questions or queries. And there's one question, sir, in the chat box. What is the age that salbutamol starts to work well?
Okay.
Asking about beta 2 receptor availability.
Yeah, very good question. Now, when we were student or in the few years back or decades back, we will learn that after 6 months only they are developing this beta 2 receptors. But can that happen actually? No, there's no, it won't happen overnight. Okay. This you rationally, if you want to use salbutamol, we rationally we should start after 6 months. But if you feel if you are having resource loss or we don't have much response to theophylline, we can use after even 4 months. But in textbook, the receptors are developing after 6 months. I think I answered the question.
Thank you, sir. But we do have some more.
Okay.
How to manage post-viral wheezing in the OPD as inhalation therapy? So where
Not
I think
available.
the question is post-viral wheezing in the OPD as inhalation therapy when inhalation therapy is not available.
Okay, again, an interesting question. Now, post-viral wheezing. Now, now it can go up to 4 weeks or maybe up to 6 weeks. If they are having a family history of asthma or multiple time they are getting this sort of wheezing, we can give a trial of beta 2 therapy. But make sure we are not managing asthma. If we are sure we are managing post-viral wheezing, we can start beta 2 or salbutamol inhalers. And if they're having a background of asthma in the family, and if they are having recurrent sort of post-viral wheezing, we need to make sure we are not managing or we are not missing asthma child. Therefore, inhalation therapy not available. I mean, I think, okay, now for the OPD, you are not permitted to use inhalers. Okay, in that case, we can use bronchodilator, but it will be very challenging to use long course of bronchodilator. Uh, I think better option to ask them to buy spacer and beta 2 agonist or salbutamol MDI. But I don't think it will go more than 2 or 3 weeks. It will resolve surely. Now, make sure you are not missing asthma while you are managing post-viral wheezing.
Yeah, that's very important. And next question is, what about theophylline and etophylline management?
Oh, again, what is the place for theophylline in asthma management? Now, it is again an interesting question. The current guidelines are not recommending theophylline for the chronic asthma management other than in the acute management. Now, aminophylline we can use for the acute management, acute space management, but not for the chronic management. Now, say for example, if we are having a kid with wheezing less than 6 months, we can use theophylline. But for the chronic management, we are hardly using theophylline or not more now. Even in GINA guideline, there's one place they are telling about the alternative usage of theophylline, but not recommended most of the guideline.
Thank you. So, and there's another question about how to differentiate bronchiolitis and asthma.
Yeah. Now the bronchiolitis bronchiolitis mainly we are not going to diagnose bronchiolitis after few years of age. Okay. Now mostly we are diagnosing bronchiolitis in first 1 or 2 years of age. Now there's a category called bronchiolitis obliterans that is different. Okay. Now for the bronchiolitis, if that is someone is coming with recurrent bronchiolitis, if it is going more than 2-3 episodes, we need to make sure we are not missing underlying condition. It is easy to differentiate bronchiolitis when they are coming recurrently. And we are not going to jump and diagnose asthma in the first or second episode of bronchiolitis. And in between the bronchiolitis episode, they will be symptom free, but not in wheezing episode. If they are having this is something like multiple trigger visa, they may be having in between symptoms as well. Not like bronchiolitis. They won't have in between symptoms in between episodes.
We can entertain another two questions which are there in the chat box. And if there are any further questions, we can
Yeah, there's a one
forward it
question
to.
asking about is there any place to
Yeah.
consider pneumococcal vaccine for child with asthma? No. If you are struggling to manage asthma, we need to manage investigation more about the asthma pathway. And while we are managing, as I mentioned in one of my slides, we need to make sure we are not missing cystic fibrosis or bronchiectasis. Therefore, we need to, while we are investigating, if we found they are having any suppuratory lung disease, we can prescribe pneumococcal. And someone with difficult to control asthma, whom having two or three types of inhaler, whom needing lot of oral corticosteroid for the control, whom had two or three admission in the ICU admission in the past. That category, yes, we can prescribe pneumococcal vaccine, not for all. But now, as a college of pediatricians, we are pushing this forward for the pneumococcal vaccine to be included in EPI. I don't know when it's going to happen, but we are pushing for that.
And about ipratropium
Yeah.
in place
What
of
is the place for
salbutamol.
ipratropium alone in nebulization for child with post-viral wheezing in the context of unavailability? There's a place. Now, we can use that because post-viral wheezing, we can easily be use propion but make sure you are not doing it very frequently. The maximum frequency we can use is 4 hourly because it can harm the epithelia or the airway epithelium. As well as it will be helpful to dry up some secretion as well if you are, when we are using in bronchiolitis or in a small kid whom can't manage their airway secretion, it will be helpful. We can use. Okay, Pulmicort nebulization for asthma. Again, it is a budesonide nebulization. This is a trade name you're asking. We can use, but mostly for the upper airway, not for the lower airway. No evidence for Pulmicort nebulization for acute asthma, but there are some studies coming up nowadays, but mostly it can be mostly used for the upper airway pathologies like croup. Okay, is it okay to prescribe salbutamol orally, salbutamol inhalers? Not okay. But when sometimes in smaller kid, if we think they are not effectively taking the inhalers, those are the instances we can use short course of oral salbutamol, but make sure you are not over dosing the bronchodilators.
So, can we diagnose and manage asthma without the consultant pediatrician is another interesting question.
Yeah, that can be because now the thing is if you have enough evidence, okay, now if you have enough evidence, if you have enough background, you can start if you can start because if they are having a family history of asthma, if they are having a exercise induced or nocturnal symptom, you know what are the diagnostic criteria and what are the four important symptoms of asthma. If you can confidently say this is asthma, that's fine. And what you can do is you can start the therapy, and if you are struggling to control the symptom, then that's the point you can refer to the pediatrician. I think you can start the treatment. No one will blame to you because we are overburdened with the asthma patients in our clinic. Therefore, no harm of doing it rationally.
It appears that that's the last question for the night. And so behalf of the Sri Lanka College of Specialist Family Physicians, sir, let me extend our gratitude. Thank you very much. And also thank you very much to the participants as well. And so good night to everyone. Thank you, sir, once again.
Okay. Thank you.
And all the participants, make sure to fill the Google link was shared. So let me share that again. So don't forget to fill that to get your certificate.
Okay.
Right?
Good
Thank you
night
very
for all.
much.
Yeah. Okay.
Right. Good night.